Hi, and welcome to our short overview on how to monitor COVID-19 patients from home to hospital using interoperability standards. My name is Stefan Schlichting, and besides being a consultant for product and service innovation at Unity, I'm also a member of the HL7 and IHE devices groups and chair of an IEEE work group for medical device interoperability. This presentation was created also with Tom Erickson from the Personal Connected Health Alliance and Todd Cooper, who's also a member of OR.net. Today we want to use a patient journey where initially the patient can use personal health devices like a pulse oximeter to monitor the most important vitals when he has symptoms of COVID-19 or has been diagnosed of COVID-19 but doesn't have to go directly into the hospital. Using the data that is captured to transmit it to the clinicians inside of the hospital for remote monitoring so that they can give an advice when it's time to go to the hospital. So when at some point the condition of the patient gets worse, its data is already at the hospital and can be used for further treatment. Our patient is admitted to the ICU and continuously monitored using a multi-parameter patient monitor. The monitored vitals are also transmitted to a central station or to maybe a display outside of the patient's room, and of course to the EMR. During the whole patient journey, the monitoring at home and in the hospital generates invaluable data for diagnosis, treatment, and research purposes. These two types of monitoring at home and in the hospital we want to use as an example on how to do that using interoperability standards. But before we continue, there's maybe an advice how the two devices differ. So they are very different in a personal health device setup. So when you use them at home, for example, just a pulse oximeter, or as in our example at the point of care in the hospital, when we use a multi-parameter patient monitor. One is a simple device having only a few measurements related to pulse oximetry, and one has typically a lot of measurement modules and is used for high acuity patients. The good news is that they basically use the same resources in HL7 FHIR to represent themselves there. I want to show you now the interoperability standards landscapes from a devices perspective. And this is what can be used to implement the remote monitoring as well the intra-hospital monitoring use case that we have talked about at the beginning. In the center, we envision a standards hospital IT comprising, for example, the EMR, lab systems, imaging systems, PDMS, and maybe some data analytics systems, but of course also the remote view to for the clinicians to check into the patients that are still at their home. So this center will be built on FHIR and of course some other standards there as well. The data from the personal health devices are transmitted using IEEE 11073 PhD standards series and communicated to the hospital using HL7 FHIR via the personal health gateway, which can be seen on over here. On the left side, up here, the in-hospital medical device interoperability is based on IEEE 11073 SDC, and it makes its data available to the enterprise hospital IT using HL7 FHIR via the point of care gateway up here. In contrast to the personal health settings at home, the devices in the hospital also exchange data between each other for certain use cases. And they even allow control with each other. So that's why this on the left side here is depicted as a circle. They exchange data, and here it's basically an upload to the gateway and from there on to the hospitals. So you can say that IEEE 1173, STC, or PhD and HL7 FHIR are complementing standards, and it's a perfect combination to implement our use case. What we want to do now is we want to have a look on how the information coming from the devices is modeled. So on the left-hand side, we have the multi-parameter patient monitor that is used in the hospital, and you can see here that it's actually a 4-layer model. Why is it this way? So on the one hand, as I mentioned before, these patient monitors are quite complex devices. They may have NIBP modules, ECG modules, temperature modules, and way more. And just one module out of this is a pulse oximeter module. They may have also below that a channel for further grouping, and here might be even more. And they have a 4th layer in the containment tree. This is the actual measurements that they do, metrics called in 1173. For example, the pulse, the saturation, and the pleth, where these are discrete measurements, and this is actually a real-time sample array, so a waveform. So because these patient monitors are quite complex, you can structure them in 4 layers: MDS, medical device system; virtual medical device, VMD; the channels which are used for grouping; and then the actual metrics. So these represent the measurements, calculations, or settings. On the other hand, we have the pulse oximeter from the personal health device world, which typically is way less complex and therefore has only 2 levels to represent. On the top, there's the medical device system, representing the device itself, and it has 3 measurements that it can do, the same as the multi-parameter patient monitor: pulse, saturation, and pleth as the waveform again. So you can remember that the PhD device uses a simplified version of the POCD device domain information model to reduce the complexity, because the devices are also less complex. If we want to now implement this or map it to FHIR, there's the PhD implementation guide, and this is actually a straightforward mapping. So you have the medical device system, which maps to the device resource in FHIR, and you have the metrics down here, which maps to observations, which then reference the device itself. So that is pretty straightforward. You can find more information on the implementation guide here. And if you now look at the POCD implementation guide, I reduced the complexity of the model a little bit. I put everything, every other module in here. And we now see here the 4 layers, and they are actually mapped into FHIR, also into a layered structure. So what we do have here, we have at the top the device, which represents here the MDS level. Then we have another device which references this device in the parallel, representing the VMD. We have one other device, the 3rd device, referencing the VMD, which represents the channel level. And then below that, we have a so-called device metrics, which reference this channel, as well as the source where they belong to. The device metrics is a layer that is introduced because it basically shows the capabilities of the devices. And what you can see here as well is that we then use observations, of course, to basically have the measurements captured. So you can imagine this as this tree here as a capability description of the device. You can find out a lot about the measurement context. So I want to come to an end here. If you are interested in joining and know more about how to model devices using FHIR, you can join us on the recently launched HL7 FHIR Gemini project, device interoperability using service-oriented SDPI and FHIR. And there is also a lot of more information on how to implement this. Furthermore, I would, before we come to the Q&As, please have a look at the current activities of IHE US, Personal Connected Health Alliance, and ONC to support standardization. Thank you very much, and I'm looking forward to your questions.